Good morning. So I'm Margrette Hanselmann. I coordinate a study called Inspire. I work for the CAH University, Kenya. So let me just go straight to it because I have 5 minutes, and I think we've spoken about adolescents, how critical the period is. I was so happy that everyone said they placed for me since yesterday. And I'm also happy that the first presenter talked about co-creation. And here I am with co-creation. That comes with several names, co-production and everything. Yeah. So, statistics again. We know that adolescence, critical period, then add pregnancy. No one has spoken about pregnancy yet. I think if you ask all women here, even the men who've experienced the pregnancy period, it's also a critical period. So here is an adolescent who is pregnant. So this study, Inspire, is being implemented in 2 countries, that is Mozambique and Kenya. I represent Kenya. I was hoping to get a Mozambique counterpart, but they couldn't make it. So I represent for both. So out of Mozambique, in Africa, by the time we're doing this proposal, ranked 4th in adolescent pregnancies, Kenya 10th in absolute numbers. Statistics show that 1 out of 3 adolescents would experience a mental disorder during the pregnancy or the year after birth, the perinatal period. These numbers are expected to rise, not a good thing. So what is it that can we do? Are there any interventions which are geared towards this issue? The answer is yes. And the problem is the interventions that exist are developed by researchers and clinicians without thinking about or engaging the user or the person who is going to deliver the service provider. So that is where Inspire comes in, whereby we engage stakeholders within the community to co-design perinatal intervention that will support the mental well-being of adolescents during the perinatal period. So that's our objective, to co-design the intervention. Not only the intervention, but how is it delivered? Aimed at improving the adolescent mental health by identifying the barriers and the enablers to maintain mental well-being during the perinatal period. So Inspire is being implemented in 2 phases. We were through with the first phase, which was completed last year, 2023, I think in August, and we began the second phase, which we also nearing completion. We'll be completing a data collection in mid-September. So what is the first phase all about? The first phase is all about the intervention co-development, which I'm going to present in this presentation. But the second phase is piloting of the intervention that was co-created in the first phase, and that's what currently happening. So how did we do the first phase? What did we do in the first phase of the project? So through a blended approach, that is implementation science, whereby we did some scoping reviews, try to learn what is it that's happening in this space, what we could learn from and what we could leverage on. And then second was human-centered design, where the co-creation came in very strongly, whereby we engaged several stakeholders. We employed different qualitative methodology. We had FGDs, IDIs, photo voices, and spiral walks. So whom exactly did we engage? So we engage adolescents, pregnant adolescents between the ages of 15 to 19 years. We engaged young women, age of 20 to 21 years, who had an experience of an adolescent pregnancy. So they had a child who was at least a year old to be included in the process. Then we also engage their partners, we engage their parents, community leaders, the gatekeepers. We also had religious leaders and service providers. So what exactly did we do? So in a series of meetings and qualitative methodologies, we tried to understand the experience, we understood the experience, the needs of the adolescents, and from this, we identified themes. The themes which emerged are, I think some have been mentioned, I've been hearing about them. So there's SRH, there was a gap in SRH, like access to FP, access to the facility, the health workers denying adolescents to access services in the facility, body autonomy. We had GBV, whereby they underwent violence in many forms, transactional sex, There was also a component of school, I think from school, whereby they couldn't resume school because of the stigma from school, stigma from parents, stigma from everyone in the community, even from the religious leaders. Also money itself. These are adolescents who do not have any skills to give money. So there's a lot that curtailed the development when it came to also just livelihoods. They also did not have information on how to take care of the children. Yeah, because they are children themselves. So how are they going to take care of these newborns? So these other stakeholders, apart from the adolescents and the young women, came in to try and understand them, to come and brainstorm and come up with and identify priorities. So we had a series of meetings, iterative meetings, which HCD calls for, and we came up with a prototype was developed from the themes and the identified priorities. So we engaged for both Mozambique and Kenya, 163 stakeholders, that is during the first phase, 56 of them being the adolescent girls and young women, 20 service providers, 55 partners and family members, and 32 community leaders, that's including the religious leaders. So the third approach, I talked about a blended approach, there were three. So we had implementation science, HCD, and now the third approach, which is systems thinking. So this is our prototype, right? We came up with a prototype. So where does it sit within the policy? So the third one is the systems thinking. Where does it sit within the system? So we have a local advisory board. So the local advisory board is comprised of people from different professions. So we have mental health experts from the DOH, the Department of Health, and also from researchers, mental health researchers within the areas. We also have SRH experts and other experts who sit within this board, and they help guide the implementation of this phase. So, for example, in Kenya, the girls talked about school was a big gap, right? But none of them wanted to return to school. While there's a policy whereby these girls must have to go back to school because they're still underage. So the local advisory board guided us on this, so this policy that this intervention must include going back to school. Yeah. So this is the proposed intervention. We call it Thriving Mamas. It was in the title, I didn't mention it. We call it Thriving Mamas. Thriving Mamas is just a general term that would that's used in both Mozambique and Kenya, but each country has its own context. The titles and how it's delivered is a bit different, a little bit different. But the content is a bit similar. Just how it's delivered differs a little bit. So when I talked about the systems thinking, why systems thinking? So that it gives us an opportunity not only to sustain the intervention, but also to scale the intervention. So this is our Thriving Mamas intervention. Thriving Mamas in Kenya, we call it Malkia Malengo. This is a name that was given by the girls. What does Malkia Malengo mean? Malkia Malengo is Swahili, which loosely translates to a queen with goals. Yeah. With goals. Yeah, like a forecast queen, loose translation. Malkia is queen, Malengo is goals. Yeah. And not only I talked about content, not only do we co-develop the content, but also the delivery and the processes. So who is delivering this thing, this intervention? So the delivery is done by a community health promoter, level 1. I think most African countries have level 1, right? So the community health promoter was also another issue that emerged during the co-designing process, whereby these girls needed somebody who was not a community health promoter, while within the policy you cannot start a parallel cadre because of sustainability. Sorry. So, yeah. And in Mozambique, it's called Kutadizana, meaning mutual support. And it's been implemented differently by an older woman and a younger woman. That is what was decided during the co-design phase by the girls. Yeah. So how does it happen? It happens in 9 sessions. 3 different ways. Adolescent girl group sessions with the mentor mother. We call her Mama Upendo in Kenya. That is a mother full of love. And then adolescent girls one-to-one, where they have tailored sessions for the individual girl. Then we have also family sessions where each girl is allowed to come with one family member or a friend to the meeting, and they can discuss and the content that was created. It's paper-based. We really wanted it to be digitized, but because of the how do you call it? Because of digitization and being in a rural area, it was quite difficult for it to be digitized. So the mentor mother is trained. The mentor mother was selected according to a criteria that was developed in the co-development. And another important thing, we also refer. We refer these girls to other services, not only within the health facility, but also other services, and they also receive standard ANC care during the perinatal period. So this happens during the perinatal period, 8 sessions during the pregnancy period, and 1 session 3 months postpartum. Right now, we are currently collecting data on it. We're doing like a small randomized control study that's incorporated 80 girls in an intervention and control. I'm hoping we'll have an opportunity to present our results on that. So we are testing for feasibility, mental health assessments, acceptability, and many other measures. Thank you.